Dear friends, welcome to this new video. We will discuss here a simple case of intravitreal hemorrhage due to retinal tear. So here it's my resident who's operating. It's his first vitrectomy, so we need to be kind with him. You can see he's having a bit of trouble inserting the trocars. He pushes a lot on the eye, what I don't really like, and then he doesn't aim very well at the posterior pole when entering. He's a bit too anterior. Here we have successfully inserted the first trocar about 4 millimeters from the limbus. Now I'm trying to show him a little bit how to do it. There, I'm pointing out the mark to position himself at 4 millimeters. He shifted a little bit, so I told him that he needs to adjust himself a bit more posterior. There we are, and I'm going to show him again how to insert. So we apply a little pressure, and then we twist to avoid pressing too hard on the globe and deforming it while inserting the trocar. He's going to try to do the same in the upper nasal. So I show him the position again. I pull the globe a bit for him to help, and he is going to insert his trocar. So there you go. He's tunneling well. That's good. Then he will verticalize. And there he tries to get in, but he can't manage it. So why can't he manage to insert this trocar? So I try it myself, and indeed the eye is very, very soft. And it's very difficult to insert the trocar. So what's happening? So I recenter the globe, and surprise, we see that the trocar valve has popped off in the superior temporal area. So that's a big issue since everything inside comes out through the trocar when we press. So we reinflate the eye before finishing inserting our trocar to have some tension, and it's easier afterwards. We reposition the valve. Fortunately, we didn't insist too much to avoid emptying the globe too much. So he is going to start his vitrectomy. It's going quite well, except that upon entering, he shakes his vitrectomy probe a bit too much. Ideally, as soon as one enters, one should start performing vitrectomy to avoid inducing iatrogenic tears. A classic intravitreal hemorrhage. The only thing to be cautious about is that since the patient is fake, one should not go too far back anteriorly. And at the same time, since we can't see very well, we need to be careful not to go too far back either. So the slightly reduced visibility is the only small difficulty in this kind of situation. But during the vitrectomy, things become clearer quite quickly. So there you go. At first, he has a bit of trouble getting a clear view, so he takes his time, and that's what is needed at the beginning. It's important to take your time to see well. That's essential in retina work, because gestures can be more or less easily picked up, but one must understand at all times why visibility is lost. Therefore, one should not hesitate to change the focus or recenter the globe, or even to peel back the epithelium if, after a difficult surgery, visibility is no longer clear. There you go. He's doing his peripheral vitrectomy, nothing special. There is no need to perform a complete vitrectomy if there is no detachment. There we had already seen that there was a tear on the ultrasound, but without any detachment, so we will quickly go and look for the tear after finishing the vitrectomy and after aspirating the blood. So there, I'm asking him to tilt his eye a little to look more towards the periphery. What he is trying to do as best as he can, he is managing quite well for a first vitrectomy. That's very good for a first case. And there you have it. He is going to try to aspirate the blood from the posterior pole. At first, his mouth was a bit turned up, so naturally it's more difficult. But at the same time, he was a bit afraid to approach the rear pole, which is normal. So there you go. Well, little by little, he managed to perform a more or less complete vitrectomy, and then we will go look for the tear that was located in the upper nasal area. So here is the tear. You can see it clearly by indenting with the cryotherapy probe. There is a slight lifting of the edges. We're still going to try to do cryotherapy, but we're going to realize that it doesn't show up very well, probably due to the uprising of the edges of the tear. So what needs to be done in this case is to perform a fluid air exchange to dry out the tear as much as possible and ensure that the edges of the tear stick to the choroid well, and cryotherapy will take effect much more easily. He is positioning himself. And there you go. In one shot, he managed to take all the tear that wasn't very wide. Here it is, a nice cryotherapy treatment, a good exchange fluid air. We can leave the patient under air to have a minimum of tamponing effect since there was already a slight detachment beginning. It's better to keep the patient on air and position them on their right side to ensure proper tamponade of the dehiscence. So that's all for today. It's already the end of this video. I hope you enjoyed it. I'll see you soon for new videos.